a lot of you know Ming already, but for those who don't know, he's a clinical neuropediatrician at Evelina Children's Hospital in London, and you've been very involved in studying A&E generally, so not just running computer-related, and so we're really looking forward to your insights on this as well.
Thank you. Delighted to be here, and we're going to talk a little bit about differences between genetic and sporadic today. And it's really very much that although we don't see it as frequently as you would see in sort of Asia in terms of the sporadic sort of causes, I've been very fortunate to work with a group of people who have been able to do, and it's essentially me putting people together that has really sort of helped with us beginning to understand some of these sort of differences. These are my disclosures, but none are related to the talk. So 3 themes only. We talked a lot about the genetic and environmental sort of influences. I wanted to focus on whether clinical or paraclinical differences can help us differentiate between genetic and the sporadic form based on data that's available. Although I am at risk of being able to generate more questions than I can actually answer, as always is the case with rare conditions. And then the management implications. Many of you have come up to me and asked questions and sort of previous sort of emails as well. What do we do? Do we need to prevent infections? How do we prevent infections? Do we treat so early that it doesn't even give a chance for inflammation to form? So this is the sort of semi preventative sort of intervention as such. But how do we apply that to the patient that first presents, where this is not even considered? So those are the 3 themes that I will look at. So even taking a step back from what Anne was talking about, the 2 spectrum of RANBP2, ANEC, and the other sort of range of conditions. We as neurologists think of infection-associated neurological syndromes in 3 forms, roughly. One is the direct virus or bacterial infection. So this is your viral sort of encephalitis. The second is that you do get a virus in the brain, but the damage is caused by the inflammation. So that's what we're interested in, the inflammatory sort of component. And then the third, which we use plasma exchange a lot, is the post-infectious. So you get better from the infection, and then as a result of the infection, your body mounts a late sort of immune response. So this is a typical sort of autoimmune condition. And classically, the range of ANEC falls within the para-infectious. So there is an inflammation, or at least in our thinking, there is an inflammation. So where does this take us? Anne mentioned the criteria that was generated many years ago now based on clinical observation of the core cohort, right? But the minute we start looking across a bigger cohort, we will see discrepancies, we will see differences. So how do we pick the most predictive features to include in the diagnostic criteria, and how do we balance the specificity, meaning if you have that criteria, you must definitely have that condition, or the sensitivity, which is essentially not missing the boat. And this is what we do a lot in neuroinflammation, whereby we use operational criteria because there's no biological measure for a lot of these to sort of look. And I just wanted to, like all, remind myself that this was the first patient I saw with ANEC, which was many years ago now, a boy who quite old actually, who presented in the pandemic of 2009 with a febrile and encephalopathic episode with profound sort of seizures. And this was his imaging, and you can see the very typical thalamic sort of lesion, and we wrote that up as the national sort of data from the UK on this sort of pandemic, only to find that many years later, after Derek had written the paper, we went back and retrospectively tested him, and he was also RANBP2 positive, but had remained monophasic all these years. So the variation sort of is there. And this is an attempt more recently from a group of us, led by Hiroshi, Mizuguchi, as well, and Russell Dale in sort of Australia, to attempt to unify the spectrum of conditions. And the reason why we felt it was important to do the whole spectrum of conditions is twofold. One is that you can certainly learn from all the similarities across other conditions, but also two, there were at least 10 to 12 different diagnostic labels across all of them. But we felt that as a group, at least the common clinical features that unifies it, obviously, is the infection, is the fever, that triggers it, and then the encephalopathy. This is how you define, a child not being right because the brain is not, functioning. And we can come back to that when we discuss, what's your threshold for initiating treatment or suspecting that this is a condition. But the four key groups there, as you can see, 3 are totally clinically and radiologically recognizable as such. AESD, which is a form of encephalopathy, whereby you usually have 2 phases of seizures acutely, then you recover, and then you have a devastating second phase of seizures, and you get this very typical imaging change. It's called the bright tree sort of appearance. And then you have ANEC. We're not going to talk about that. This is your typical sort of thalamic lesions there. And then you have a milder form called MERS, which is where the splenium, which is the part in the corpus callosum is where all the tracts cross and talk from the right to the left, gets a little bit inflamed during a viral infection, sometimes rotavirus, and sometimes a whole host of other. And then you get the severest sort of extreme, whereby you have fulminant cerebral edema, and you have shock and sort of multi-system involvement. And this, we think, obviously, is a syndrome. It's just remembering that all this is unified by an operational diagnosis, not a mechanistic diagnosis as such, recognized by the onset by following infection, usually influenza, but not exclusively influenza. And then we park 2 other syndromes in there, whereby we know they are triggered by sort of infection and inflammation, but we don't really know whether they're mechanistically the same. So one is a refractory seizure syndrome, and the other is a very peculiar sort of half-body syndrome, whereby after an infection, you trigger seizures on one side. Sometimes you don't move that side, and then that side, generates this sort of epilepsy, sort of syndrome. As I said, remembering that we're only doing this to make sure that we include as many, of the patients as possible. And this is recently published by Hiroshi. So we will come back to what the infection-triggered group might sort of tell us, towards the end. Okay, so again, this is a nice review from Mizuguchi, whom you heard from Kim first described ANE, which is the non-genetic variant of this, because they see a lot more of the sporadic form in Asia. And he reminded us that, like all things, it's worth thinking about mechanisms. And whenever you see lesions in the brainstem, lesions in the basal ganglia, lesions in the thalamus, you need to think about metabolism. And this is more of a sort of philosophical, sort of evidence-based sort of discussion about how we should think about it rather than definitive evidence. And he makes good cross-references to conditions that are quite similar. So whenever you see lesions in the thalamus, you need to be thinking about toxins, and is there an energy deprivation, and hence mitochondrial sort of syndromes as such. But it's to remember that when we think about those, we think about those being a secondary problem rather than primary problem. So what I'm not suggesting is that ANEC is a primary mitochondrial condition, but in treating the condition, maybe we need to be thinking about sort of energy metabolism as a definitive or different target as such. Of course, the immune we've talked about already in the different viral pathogens. And the third component that he was a big proponent of is the excitotoxicity. So every time you have inflammation, every time you have seizures, you're going to be producing a lot of neurochemicals, and too much of these neurochemicals is really toxic. So this is glutamate, this we know causes a lot of energy failure and subsequent toxicity. And there are many examples of that in other forms of conditions that we see in neurology, like SCN1A, that does appear to have this form of neurotoxicity. And he was sort of right to sort of point out the correlation between specific viruses like influenza with some of these more specific sort of phenotypes. So you can see there that influenza with ANE, AESD that I mentioned already, and RSV with sort of MERS. So again, the question of why, and we know that in a pandemic of sorts, even with COVID, but all of us were hit with the virus, but yet the susceptibility is so specific to a group of patients. Of course, the ANE1 mutation may just give you a little proportion, and in Anne's group, 40% of the group had the sort of mutation. So it was just to introduce you to this that needs really no introduction, because in the next 2 days you'll be hearing about how this protein can influence a whole host of things. I'm certainly not an expert, but the reason to highlight this slide is that if you look at the imaging of patients here, there's really not as much thalamic change that you can see there. So very much the spectrum of condition, and I'm pretty confident that maybe in 5 years' time or 7 years' time, I picked up 7 because 7 is sort of a nice number, that we would be thinking about moving to describing this perhaps as RANBP2 disease rather than ANE1, because the spectrum is going to be different. And this we learned from another mutation, and this is a mutation that is involved in a inflammasome modulator. So the likes of Taco will tell you that the inflammasome is a mechanism in the body that has got lots and lots of players, which essentially moderates the amount of inflammation there is, either suppressing it or increasing it, like in an infection. And these are families, 4 families with the mutation, and 4 of them have an ANE-like phenotype, 3 have an ADEM-like phenotype, and 1 an acute fulminant cerebral sort of edema. So this really tells us that we need to be thinking that this is a mutation-specific spectrum, as such. And then the story repeats itself with DDR1 deficiency, whom Vanessa works with very closely, first described this sort of some years back now, and we saw this as a susceptibility to brainstem inflammation, because the deficiency in the virus, the deficiency in this protein makes you not able to clear the virus as such. And we know that this protein is expressed quite a lot in the brainstem and the spinal cord as well. And last year, this was published in a series of patients who were presented with encephalopathy or encephalopathy in a sort of, I think in the Middle Eastern sort of cohort. So one might not have automatically picked that up unless you look carefully, but we found out that the one patient had DDR mutation, and the sibling is the one with the acute fulminant cerebral edema as well. But you can see the 2 very clear, thalamic lesions there. And I'm told that it's unequivocal, the sort of mutation here for DDR1, although I am not the DDR1 sort of expert as such. So you've asked the question and in part answered it, and it was just to highlight that if you look at influenza and RANBP2 sort of outcomes, the 2 key things you need to be aware about when you compare the literature. One is that if you look at sporadic, all the sporadic data often comes from Asia, where there is very little genetic ANE. In fact, we talked to Terence, who has contributed the most, I think, to the ANE sort of literature from Singapore. All the patients that he tests, less than 5% have the mutation, and Singapore is probably the only nation that would do systematic testing. If you were from Japan, if you were from India, you would only test if they recurred or if something was slightly sort of atypical. But in Anne's or the Canadian sort of cohort, you can see there that I think 2 important bits here to bear in mind is that they are super early diagnostic sort of diagnosticians and super early intervention. So virtually every patient is treated within 6 days of the onset of symptoms. So the relatively good outcome from that group, or the relatively
because everyone was treated relatively well, it may be difficult to discern the differences, between the two groups. And we'll come back to that at the end as I present to you some early data from some individualized patient data that we have. So outcome not that different between RANDBP2 positive and sporadic, other than the recurrence risk, which we know sort of anyway. The key question, of course, is any more severe? And this is part of the sort of gene environmental sort of interaction. But of course, we also know that usually all this data comes from the time where influenza is actually more neuropathic as such. It goes through cycles. So when you have a surge, you get more of it. But when you get more of it, you get more severe forms as well. And we've seen that in the H1N1 and H3N2 sort of outbreaks, at least in the UK. And you can see how rare it is. And this was events as such, I think, from 4 less patients. And they're certainly more severe in terms of hospital stay, PICU admissions, and mortality, with A&E associated with influenza. And if you know that there's such a small group of patients already, and you're trying to dissect out the genetics as well, at best you get sort of an observational sort of visual presentation rather than hard data that it is worse as such. So getting A&E when you've got the mutation and when you've got influenza doesn't appear to be sort of good news, and we all see that. But what is the data out there? And I'll try and come back to that sort of right at the end. And then the big question is COVID, right? Did COVID cause a slightly different form of A&E? And certainly for us, and I'm told the Italian group and the sort of American group as well, who have since published, particularly involved in the first wave of COVID on the neurological sort of syndromes associated with that. Both ANEC and infection triggered feature very little, considering the amount of patients that got the COVID. So it is not big. But when it came to the second wave, particularly hitting the countries that we know have very more commonly sporadic A&E that perhaps is worse, like Asia, Taiwan, and Japan, they saw a higher sort of incidence of some of these syndromes. Remember, in fact, noting that not all of them were sort of ANEC as such. And then Vanessa, who worked with Terence in Malaysia, who then spent a year with us, summarized that, identifying that once there was an uptick, it wasn't a big a difference in terms of SARS-CoV-2 associated sort of ANEC as such. Okay, so what am I going to share with you? Is not yet published, and it's in the very early phases of being sort of looked at. And when we derive, or when we talk about what consensus we would use for defining some of these syndromes, the same group of us decided to review the literature and use a technique that has been used in a lot of conditions, particularly rare conditions like cancers. We've used that in rare inflammatory conditions of individualized patient data. So these are all published, data out there already, and you can extract, all the data that you want from that data. And of course, the key bit that you mentioned is publication bias. Individualized cases would only publish if they're a bit unique or slightly different. So bearing all that in mind, this is what we can sort of, split. I don't want you to see all of those, but we'll focus on the A&E data only insofar that this is going through sort of a data cleaning process at the moment. But we are planning a meta-analysis of about 2,000 cases of patients with a range of infection-triggered encephalopathy syndrome from, 660 papers. So what can such level, data tell us? And you've got to be very careful looking at these sort of data, and at each point, make sure that your analysis is the one that's going to help you answer that question. Because if you look hard enough, if you analyze the data hard enough, you will find something that may actually not be relevant. So you can see there that if you look at sort of A&E itself, and I'm only going to focus on the specific question I was asked to sort of address today, which is sporadic versus genetic. So there were 77 cases with ANE1, 240 sporadic cases. So again, a health warning here that the sporadic cases are patients that were genetically tested and negative or remained relapse-free. So we cannot include only patients that have been tested, otherwise there'll be very little data sort of from Asia as such. So with that in mind, what could it tell us? We know that they are younger. But like what Anne had showed, there wasn't very much difference between how the patients presented, both in severity, length of stay, sort of interventions, and also sort of intensive care interventions. We might have to rethink a little bit about how we define that. But I'm going to leave that to the discussion if that sort of comes about. But mortality was certainly higher in that group, but the disability in survivors did not differ significantly. So there were neuroimaging differences. In patients with ANE1, there was more external capsule and insular involvement. There was more medial temporal involvement. And as you remember, some of the definitions were already observed by Derek in his sort of papers on the ANE1 sort of version of that. And in the sporadic form, probably because there's a little bit more inflammation, maybe the cerebellum was more involved as well as the white matter, being more involved. And Vanessa has actually done the early part of this work from the group. So what about systemic features in ANE1 and sporadic cases? So blue is ANE1 and sporadic being in red or orange. And you can see there that systemic features like shock and coagulopathy and a low and a low platelet count was more frequent in the sort of sporadic ANE. But inflammation, perhaps, as inferred by liver enzymes, procalcitonin, and CSF phagocytosis, was significantly more, common in the ANE1. So I'm going to not dwell any more into this data because what we're trying to look at is the treatment, data, which is entirely challenging, being able to compare speed of delivery to the types of treatment. So I'm probably going to finish there now, but do have some treatment data to present on tocilizumab if that becomes a question, sort of later on. But I wanted to suggest some sort of discussion first before we show the treatment data, because it's not really relevant to the differences between ANE1 and sporadic. So thank you for your attention.